Eileen, we've talked about some neoadjuvant approaches. The cooperative groups are looking at this as well as some pharmaceutical companies. What are the trials that are ongoing?
Yeah, I mean, and to echo what John and George said, it's an area of transition in management of patients with localized pancreas cancer. Firstly, the recognition that some patients are potentially downstaged, and whereas in the past we would not have considered them candidates for the operating room, that's changing. So there are a number of studies now in the public network looking at preoperative treatments. So there's the SWOG trial, the S1505, which is comparing gemcitabine and nab-paclitaxel and FOLFIRINOX in resectable pancreas cancer. And I'll come back to this because this has been interesting. And then there's a parallel study in borderline resectable pancreas cancer that's just opened by the Alliance. And this is using a backbone of modified FOLFIRINOX with plus or minus radiation. But one of the learning points on this resectable study is exactly what you said, that even with multidisciplinary expertise, there's still a lot of shades of gray in terms of where resectable ends, where borderline resectable begins. And, you know, it's a lot of judgment and interpretation, and I think not necessarily consistent. So these are hard, but I suspect what we'll see happening, even though we don't have data to support this yet, that will move at some point to, irrespective of whether borderline or resectable, to neoadjuvant-based treatment and surgery to follow. I mean, we're still in a surgery-strong institution, so it's our default position, I would say, in the absence of a trial. But clearly, this is a change that's happening in pancreas cancer.
And we're seeing too that even, you know, you give some chemotherapy up front, and the imaging may be better, but still the radiologist is calling what we would say is unresectable. And then they go in and operate anyway, and it comes right. You know, it's different than the imaging.
Yeah.
So I do think our default is to at least explore that patient, even if we don't think we've cleared the vessels like we think we have, unless there's very, you know, encasement or something like that. But if it's a close call, we will err on the side of exploring that patient.
Yeah, and you think about these neoadjuvant regimens both in patients who have resectable disease as well as borderline resectable disease. There's a lot of questions out there as to how to optimize. So, Caio, besides chemotherapy, tell us a little bit about the role that you see for radiation therapy for the treatment of these borderline resectable pancreas cancer patients.
Absolutely. I think this is a question that has not been yet answered. The role of radiation is being studied by the Alliance ongoing clinical trial, but the way radiation is given is novel, and in my opinion, is a better way to give radiation therapy. The old fractionation, you know, of 50 gray given over 25 fractions with big ports may not be the best way to deliver radiation in pancreatic cancer. The optimal way may be by decreasing the number of fractions and increasing the dose. And the Alliance is studying the role of two modalities of hyperfractionation. One is by SBRT that give very narrow margins. Patients have to really have control of motion, take deep breaths. So high dose of radiation is going to be delivered to the cancer bed. The dose of that in that protocol will be a total of 53 gray. Will be 33 gray. Going to be 5.6 gray over 5 days. In institutions that cannot deliver SBRT, they are going to be given the hypofractionation, that is image guiding. It's going to be a little bit of lower dose to the tumor bed, but it's still a higher dose than is given in a shorter period of time that is given with the standard fractionation. And I think that's going to pave the way to really understand the potential benefits of radiation in this disease.
So Eileen, tell us a little bit more about your experience with borderline resectable disease.
Yeah, so to follow on the point Caio just made is, you know, we want to know what radiation adds in this setting, and it may be one of the major settings in pancreas cancer where there is a clear utility in terms of affecting the ability to get a negative margin, and that's, I think, very important. And some of these techniques may not truly optimize the oncologic effect against the tumor, but may facilitate getting that negative margin, which from the oncologic point of view is the optimal operation that you want to do. So answering this question, I think, is important. You know, we're struggling with where radiation fits in the adjuvant setting, and there's a lot of controversy around whether we should or shouldn't do it. We'll hopefully have some data in the next few years, but this is in contrast to the LAPO-7 study, which suggested that there may not be a role routinely for the use of radiation in locally advanced pancreas cancer. So I think just want to bring up the point that this is an important setting to consider the value of radiation, and we have yet to declare whether it should be the routine standard in borderline resectable disease.
So
We really have to pay attention to quality assurance with the radiation. And the LAPO-7 that was presented today, I thought that was really interesting. 31% of radiation was on protocol.
31.
31%. And Ross has been, Dr. Abrams has been saying this for some time now from the RTOG trial, that being on protocol is important in terms of outcome. And I think the American experience is that, you know, our radiation colleagues do a good job of staying on the protocol, and that didn't happen in LAPO-7. So I don't know if that's a real answer, but we have to pay attention more and more to that.
And that negative margin you mentioned, Eileen, is so important, right? Because if it's not, then you might as well have not done the surgery in terms of outcomes. So it's really important. And this is in the backdrop of a operation that actually, in the end, only cures a few people. And so we have to pick our spots and try to deliver all of that, because we know it translates into some significant morbidity. It's a big deal operation. And pick the right patient, get that negative margin.